Hello, this is Dr. Tony Clark with learninganesthesia.com, and today we're going to have a case lecture on ALS, or amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. We're first going to talk about the pathophysiology, some of the signs and symptoms, some of the signs of respiratory involvement, including PFTs, and then we'll discuss the anesthetic considerations with ALS. Amyotrophic lateral sclerosis is a disease of both upper and lower motor neuron nerve degeneration. So I have here in green upper motor neuron number 1, which can be involved in the cortex and can also be involved, circled in 2, in the cortical spinal tract. This disease also can affect the lower motor neurons in the anterior horn, which eventually synapse to cause muscle contraction. This disease is specific for upper motor neurons and lower motor neurons that are involved in muscle contraction. So patients present with muscle weakness, but typically sensation is intact. Because this disease involves both upper and lower motor neurons, it can sometimes be a little bit difficult to tease out exactly what's going on. So let's talk about the different signs and symptoms for upper versus lower motor neuron on the table on the right. With our upper motor neuron diseases, typically the patients have an increase in tone. With lower motor neuron, they have a decrease in tone. For atrophy, typically patients with upper motor neuron diseases do not have muscle atrophy because they're hypertonic, or they have a high tone. With lower motor neuron diseases, because they have a low tone, the muscles tend to atrophy. With upper motor neuron diseases, there does not typically, they do not have muscle fasciculations. With the lower motor neuron disease, they do have muscle fasciculations. For upper motor neuron diseases, they tend to become hyperreflexic. In lower motor neuron diseases, they become hyporeflexic. The reason being with upper motor neuron becoming hyperreflexic is they do not have the inhibitory pathway to inhibit these reflexes. And weakness for upper motor neuron diseases typically involves muscle groups versus lower motor neuron diseases. It's typically the individual muscle that is weak. So a patient with an upper motor neuron disease may have a hypertonic, not atrophic, and hyperreflexic arm versus a lower motor neuron disease. They may have a hypotonic and atrophied bicep that is hyporeflexic and presents with fasciculations, just for an example. The reason I include this table is because the difference between upper motor neuron and lower motor neuron diseases is commonly tested. And with ALS, it's a good opportunity to review that both may be involved. So let's say that you're anesthetizing a patient with ALS and you're trying to get an idea if they have any respiratory involvement. Some things you can ask are, do they have any dyspnea on exertion? Or just any shortness of breath in general. You can also ask their exercise tolerance. Another thing that you can ask is, have they been to a pulmonologist and received pulmonary function testing? With ALS, PFTs can be somewhat helpful in seeing how much the respiratory muscles are involved. One of the signs is that their FVC, or forced vital capacity, will be decreased. And typically it's less than 75% of normal. That will clue you in that they are starting to have some respiratory involvement and may need prolonged mechanical ventilation after the procedure, or also might clue you in that you may not want to do this procedure under moderate sedation. Another thing that we should be worried about is, do they have any airway involvement. Meaning that, are their airway reflexes compromised? Some of the things that I ask are, do they have any fasciculations or weakness of the tongue? Do they have any dysphagia or difficulty swallowing? Do they have any really bad acid reflux or feel like they are regurgitating foods after they eat more than normal? Those might clue you in that they are starting to have some airway involvement, and their airway may be compromised very easily. So let's talk about some of the anesthetic considerations for these patients. Number one, because they present with weakness and can present with weakness in the airway, as we mentioned, they are at an aspiration risk. Which means patients must follow the strict NPO guidelines. You probably don't want to use an LMA, and I would highly consider doing a rapid sequence induction with them. I would also make sure they're very awake before extubation. This is not somebody that you would want to extubate deep. You would want to make sure that their airway reflexes are intact before you extubate them. So let's say that you do induce anesthesia with these known aspiration risk factors. What are some things you need to consider with general anesthesia? Well, first, I would consider, number one, a multimodal pain management approach. What I mean is decrease the amount of opioids that you use so that you don't further decrease respiratory drive. And while we're talking about that, I would limit the amount of benzos as well for the same reason. For muscle paralysis, during these cases, avoid succinylcholine. It can lead to rhabdomyolysis, having an increase in potassium, and which can lead to cardiac arrest. If you do want muscle paralysis, don't use succinylcholine, as I mentioned, because it will cause rhabdomyolysis, hyperkalemic cardiac arrest. So if you do want muscle paralysis, use a non-depolarizing neuromuscular blocker. But you may want to decrease your dose because the patients are already weak and may not need as big of a dose as you would typically give. So let's say you want to use other anesthetic techniques. Regional anesthesia may be your best option. There have been some reports or some concerns of exacerbating disease process with regional anesthesia, but it may be your best bet since these patients are at aspiration risk and you really don't want to decrease their respiratory drive with any benzodiazepines or opioids, or give them any sedating drugs. Neuraxial anesthesia, Well, it can go either way. Most people are okay with epidural, and the literature says that people do just fine typically, but there's a big question mark with spinal anesthetics, whether or not that will exacerbate or make the disease process worse. So these are the considerations in patients with ALS. They typically have upper motor neuron and lower motor neuron disease symptoms. They may have respiratory involvement, which may include dyspnea on exertion, shortness of breath, and poor exercise tolerance. If you're really unsure, you can check PFTs and you will see that their FVC is decreased. If you're wondering or not if they have airway involvement, you can discuss with them if they've had any weakness or fasciculations in their tongue. You can ask about dysphagia or GERD symptoms as well. And then as far as anesthesia, they are definitely an aspiration risk. They should be strictly adhered to the NPO guidelines, and I would make sure they are completely awake before extubating them. If you are doing general anesthesia, I would use a multimodal pain management and avoid benzos and opioids. I would avoid succinylcholine since it causes rhabdomyolysis and a hyperkalemic cardiac arrest. And if you're using a non-depolarizing neuromuscular blocker, you can decrease the dose typically. Other considerations, regional is typically safe in these patients, and epidural anesthetic is typically safe, and spinal is still questionable. Hope you enjoy this lecture. Thanks for checking us out.